right, so welcome. This is AFC Training Files. I'm Dr. Jay Snibo with AFC East Mesa Clinic. I'm going to be going over Shoulder WorkSpace, but first I want to start off with the properties and principles and also the whys of what we're actually doing this for, so you actually know what you're targeting and how to explain this to patients. So when I look in terms of workspace, essentially what we're doing is moving any joint. Right now we're mainly targeting the glenohumeral joint and how you can move that in the biggest circle you possibly can. Now the reasons why that is important is because we can train the joints different than ligaments and tendons, different than muscles. And just even by knowing how to do that, we can better fine-tune the rehab. So with the workspace, we're targeting the joints and to a certain capacity, the ligaments and tendons as well. And those are those are the two areas that most clinics, most physical therapy departments, most practitioners are lacking when they're dealing with any type of tissues. And I've looked and assessed and shadowed over 80 different clinics through multiple states. So I have a good idea on and that's physical therapy clinics, chiro clinics, also a few medical clinics, naturopathic clinics as well. So this is coming from a larger line of research, and no one is really targeting this. Very few people are. So the reason why I am pushing for workspace as much as it is because it's targeting something that one will help a whole heck of a lot of people. It'll create a better foundation which you can work from. It'll decrease risk of injury. It'll help increase blood to certain damaged tissues. It'll factor out and break down scar tissue. I look at it like brushing your teeth, but for joints. And ideally, you want to have someone do this on a daily basis so they can keep monitoring themselves either from workout to workout or just on a daily basis. So as I go through this, I'll discuss the structures so you can see exactly what's going on there. I'll also demonstrate level 1 movement versus level 2 because that also matters as well. And we'll go from there. So let's look at the screen so we know exactly what we're actually targeting. So with the shoulder, there is a ball and socket joint. The humerus moves upon the shoulder girdle. Now, with that, there's degrees of freedom that one can move within. However, if you have past injuries, if you have overall muscle tightness, that will restrict certain movements. And especially for shoulder patients, I want you to also be aware of a couple things. If someone can't lift their arm overhead, usually they compensate in their lower back to get movement overhead. I see that a lot in like Olympic lifters. I see this a lot in any high-end athletes because they're really good at compensating. But however, that breaks down other aspects of the body. Like your lower back doesn't move as well as your shoulder moves as the shoulder, if we will. So if there's any problem with any joint, it'll cause overlying muscle tightness. And that's the shoulder, that's the spine, hips, knees, ankles, elbows, wrists, anything involved. And the first line of communication to the brain and nervous system is the deeper structures first, which is why, like I said, if there's a problem with the joint, it causes overlying muscle tissue tightness. So based on type 2 afferent nerves, or nerves that go from the body back to the brain, that signal will be sent first and it'll be sent back to the tissues before any of the muscle spindles, before any of the Golgi tendon organs send the signal back up to the brain. So just by knowing that, we can use that to our advantage, to where we want to target the deeper tissues first and then overlying muscles next. So we're going to start with rotational movements. So for the shoulder, there's a capsule, there's a membrane, and the membrane helps move the bones evenly throughout any range of motion. So as I look through here, this is all a membrane, and it's made up of the capsule itself. And we also have a fun little tendon, if we will, but that's also part of like the sheath to the bicep head. So as we add on more layers, the next are going to be ligaments. And ligaments are connecting bone to bone. And as you can see, where are most of the ligaments? They are on the front aspect. I'll add on more muscles. The muscles then are the rotator cuff muscles on the backside. So we can look at this in a couple different ways. The ligaments often support the front, but that leads to a lot of posterior capsule injuries, because if you have overuse of either bench press or movements in front of us, because we live by looking forward, that's where you have to also look and see how can you adapt the ligaments and tendons on the front to also turn off tightness of the muscles in the back. And that's usually by working behind us in rotational work first, so you can target those. So, and then there's also the subscapularis, which is a muscle that comes underneath the armpit. Now, usually if there's shoulder problems, I always like targeting and looking at that muscle as well, because that'll control like retraction, protraction, and also same with the serratus anterior muscles. But in terms of the shoulder workspace, all these tissues factor into the movement that a person can move within. So we want to make sure we're paying attention to all those. But I'll keep adding in layers. So like going back to the capsule itself, then there is the rotational ones to where they start and they come down in an angular formation to where then the muscles are on the opposite side. So let me take apart a layer of the muscles here. So as you can see, mostly on the front, here's the capsule, and then also ligaments on top. I'll keep adding ligaments so you guys have a good idea. So where the AC joint is, and then some more of the other ones with some bursos as well. So first line of tissue is rotational capacity, and then it's overlying muscles. So now that we know that, and now we know that the body adapts to forces over time, we can target the joint capsule by moving the arms through the biggest range of motion we possibly can. Now, in terms of level 1 movement for the shoulder, especially for the glenohumeral joint, which will move a little bit different from the AC joint, different from the scapulothoracic joint. So with this, what we want to do is making sure we're only moving this glenohumeral joint mainly to where I want the arms completely contracted straight, the torso not rotating, so keeping that nice and straight. You can do the seated, you can do the standing. Doesn't matter too much. I'll demonstrate here. So level 1 movement, we want to start most people on. And this is for, I'd say, almost anyone and everyone, mainly because it's a tool that they can have for the rest of their life. It's really, really good for a lot of the stuff I've already said previous, but it's targeting structures that are definitely lacking in almost everyone. So level 1 movement for shoulder workspace is going to be having them move their arm through the biggest circle they possibly can. Nice, easy movements, just getting used to how to move in the biggest range of motion they possibly can. So what we first want to have them do is have the thumbs facing straight forward. What we can do is come across the body and nice, easy movement. I don't want to stress that angle of tightness, but just getting used to the movement. Now, when our hands go up over top, the thumb should be facing away from us. And then as we turn, the thumb is going to be going and moving towards the head. As it moves towards the head, we're going to rotate back and around, making sure that the torso doesn't rotate with us, and then the arm's completely straight. And then when they come back here, wanting to have the arm straight back and then down. Opposite direction, so you want to move clockwise and counterclockwise. First come straight back and then can slowly rotate externally, coming all the way back up and around. That's level 1. And we want to keep them on that for more than likely till the first re-exam. And we can adapt them and we can push them and graduate them to level 2 when you start noticing increased range of motion, decreased pain, less sensitivity to the area. So those are about 3 factors I want you to pay attention to. And usually if they go through this on a consistent basis, they're going to reach those levels much quicker than the first re-exam, but still habits are very, very important as well. So every time in the office, ideally teaching them in the workspace, having them do it, and then also providing examples as well. So let's say for the patient, they're increased range of motion, they're feeling better, less overall tightness. For them, we want to adapt them to level 2. Now, level 2 is the same motion. However, we're going to be pushing the range of motion a little bit more. So there's going to be a line of tightness to where they can't go any more without like compensate or twisting the rib cage or bending the elbow. And that is where we want to push them along that line of tightness. Now, for most people, we want to start off with lower intensity to where when they push into that line of tightness, let's keep it about 25%. Over time, you can have them go into 50% intensity, then 75 and 100% intensity. And when I say intensity, it's the act of actually moving and going incredibly slowly, but trying to move the arm into that line of tightness. And you might be some shaking, like that's cool, that's normal. If there's guarding, that's also normal as well. Okay. Now be very cautious and careful with the intensity and not to accelerate them too quickly. You'll know if you're accelerating them too quickly, they're going to be incredibly sore. They could decline in some of their ranges of motion. That's when you know you have to either back off the intensity, and then even mix in level 1 movement, just nice, easy, and then you can build up from there. So level 1, nice, easy movement, getting used to the movement itself, clockwise, counterclockwise. Level 2 is pushing that line of tightness as much as you can. And over time, you can have them do the circle over time. Say, like, you want the circle done for a complete movement within, let's say, 30 seconds. So they would have to complete the big circle one way, 30 seconds, and 30 seconds back as they're pushing that line of tightness. Okay? Now, in office, you can also add in a couple other things on top of the workspace as well. I wouldn't adapt too many things right away. Just get used to the movement first, and then you'll be able to teach that to others. But when you increase the intensity of your nervous system, so like, for example, when you're bench pressing or squatting, there's an amount of intensity or effort that you have to give to get that bar up, to get that back squat up. And it's that line of intensity that you can drive into the joints, that you can drive into the ligaments, tendons, to the muscles. That is how we're able to build up the structures. That is how we're able to break down and heal people with degeneration, to where we can increase the joint space. We're now seeing we can increase the knee workspace as well by healing the meniscus. And like there's so much potential into this, and there's not as much long-term lines of research with this, but you amalgamate or you group a bunch of research together, and I've noticed over the last few years that people are starting to heal much quicker. We're starting to help with a bunch of conditions we weren't able to, and that is the reason why we're targeting the joints, ligaments, and tendons. And the ligaments and tendons, and how you can train those, is either elongation of muscles to where at the end range of motion you're funneling energy into the ligaments and tendons, or any isometric contractions at end range of motion too, and then holding and squeezing. That also bleeds forces into those tissues. Now, the thing that's kind of unique with this whole situation is every muscle fiber is different than a bunch of other fibers. So the sarcomere is the smallest functional unit of any muscle cell, any muscle fiber, to where when the nervous system attaches itself to the motor units, if they don't have as many motor units, they're going to be limited in their strength, and they're also going to be limited in the degrees of freedom or ranges of motion they're able to move. So as they increase the intensities into those tissues, we're able to recruit more neurons, and motor units so they can better utilize all those to more of the muscles, more of the ligaments, the tendons, and whatnot with that. So that also factors in as well. But going back to the point I've made in the office on how you can funnel the intensities, what we have been doing is if you push into the wall, or even if you like squeeze your quads, or you squeeze any of the muscles for 10 seconds at 25% intensity. So for example, pushing into a wall. Now be careful with the structure of any place. If that is the case, I just want you squeezing the muscles. So like, let's say for the quads, for example, I want them squeezing the quad at 25% intensity for 10 seconds. And then ramp up to 50% for 5 seconds, 75% for 3 seconds, and then slowly back off from there. So now that we ramp the nervous system up, then go back into the workspace and push in that line of tightness. So ideally, we can do this either by squeezing the muscles of the quads, legs. We can do this by pushing into the wall. We can do this by either lifting a bar for like deadlift. It's gathering all that energy and then funneling it into whatever structure you want to rehab. So that is another aspect, but first things first, get used to the movements of level 1 workspace. There's a sheet that I have that explains a little bit more in depth on level 1, and then there's another one that explains a little bit more in depth on level 2. And you may notice for some of these that there's like zones, like zone 1 versus zone 2. That's just so you can better document for the person. Like, let's say they came in on their day 1 and there was restriction coming overhead. You can mark on that sheet saying, or just either squiggle line, either can't move there, so you can monitor their progress, and that can be on a re-exam as well. There's also a QR code to where if they scan that on the bottom, we can go paperless, and that can open up to another link, and that other link can then be pulled up on their phone, so they have it with them, and they just can create a file for that on their phone. So there's options. It's more accessible for patients, but this is something that where it's highly recommended for anyone and everyone, whether they're in pain or not. Ideally, it even works better out of pain because we're skipping a step of not having to deal with pain. And pain, I want you to be cautious of moving into pain. So like, let's say there's sharp pain. I want them to decrease the movement and then go around it. Not moving into pain is a huge factor into this. So, and also so you don't accelerate them too quickly as well. This is a thing and an aspect where you want to look at this long-term approach in terms of months, years, and not as much as a quick fix or a quick get out of pain, but it all factors together. So that is Shoulder WorkSpace with a bunch of other properties, laws molded together, and a couple other aspects with that. Again, I'm Dr. Jason Ivo. This is AFC Training Files. Please feel free to email me, ask any questions you have about anything. I'd love to help out any way possible. Thank you. We'll see you soon.